Good morning, everyone. I'm Dr. Adrian Sequeria. I'm professor of clinical medicine from LSU Shreveport in Louisiana, USA. I'd like to thank all the organizers of Avatar for having me on this program this year. My topic for today is the basics of ultrasonography. I have no conflicts of interest. This is the overview of the topic that I'm trying to cover over the next 20 minutes. We're going to talk about definition, how does ultrasound work? We're going to talk about the probes, orientation of image modalities, and if you have time, artifacts as well. So the normal human ear can hear sound frequencies between 20 to 20,000 hertz. Anything above that falls in the domain of the ultrasound waves. For the purpose of diagnostic ultrasound, the machines use an ultrasound bandwidth anywhere from 2 million hertz to 20 million hertz. So the next we talk about how does the ultrasound machine work. So the ultrasound machine gives off a current that goes down the probe, and as the current comes to the edge of the probe, there are a bunch of piezoelectric crystals. So the current makes these crystals vibrate, and when these crystals vibrate, they generate ultrasonic waves. These waves then pass through the tissue, in this case the chest, hit the heart, and come back. When they come back, they again go and hit the piezoelectric crystal, and now the crystal vibrates again. But instead of generating another bunch of ultrasonic waves, the crystal now generates an electric current, and this electric current goes down the probe back to the ultrasound machine, and then the machine generates a image. Let's talk about probes. There are three main probes that are used for ultrasound by the ultrasound machines. On the far left is the linear probe. The linear probe, also known as the vascular probe. This is the kind of probe I use to evaluate arteriovenous fistulas. These probes have a bandwidth of 5 to 20 million hertz. Because of their large wavelength, they unfortunately have poor penetrations, and the maximum depth that they can go to is anywhere from 6 to 8 centimeters, which is just about enough for us to evaluate our fistulas. Because of their high frequency, they also have great resolution. On the far right, we have the phased array probe, also known as the cardiac probe. This is the probe that is used by the echocardiographic tech to evaluate the heart. These have a frequency between 2 to 8 million hertz. Because their frequency is slightly less compared to the linear probes, their penetration depth is better, but this comes at a cost. The resolution isn't all that great. The beauty of this probe is that it is able to squeeze between small spaces, such as in between the ribs. The one in the middle is the curvilinear probe, also known as the abdominal probe. This probe has a frequency between 2.5 to 5 megahertz. Just like the phased array probe, it has beautiful penetration, and therefore it is used to evaluate the abdomen. Unfortunately, because the wavelengths are short, the image resolution is poor. This is the generation of handheld ultrasound probes. And here on the slide, I've shown you 4 examples of different handheld probes. Now, many of them use piezoelectric crystals, except for the butterfly machine, which works on transducers. And because of this one probe is able to perform the function of a linear probe, a curvilinear probe, as well as a phased array probe. With respect to the other machines, you might have to have extra probes. Now, coming to the anatomy of the probe, so the most important thing when you look at a probe is to look for the marker. Now, this marker or indicator can be of various definitions. It could be just a light bulb that is sitting there. It could be a depression or literally a marker. Now, this is the leading edge of the probe, and this end of the probe has to be usually directed towards the patient's right or towards the patient's head. This is important in getting an idea of the orientation of image on the screen. So just like the probe has a marker, and I'm showing you here in the diagram with my cursor, on the far right is the image on the screen. And you can see the screen also has a marker as depicted by the white arrow. So generally speaking, both the probe marker or the probe indicator and the screen indicator should be on the same side, so that you have an idea of the orientation of the image. So in image 1, both the probe marker and the screen marker are on the same side. Therefore, when the probe tries to image this object here, the left side of this image has depicted by the red arrow falls on the left side of the screen, which is on the same side as the marker on screen marker. Now, if you flip the probe by 180 degrees such that the probe now is a marker is on the right, but the screen marker is still on the left. When the probe takes an image, it is viewing the side of the image that is depicted by the green arrow. And this side of the image does not fall now on the right side of the screen. It falls on the left side of the screen. So it's important to be aware of this. Now, while the ultrasound machines typically have the indicators on the left, the echocardiogram machine tends to have the indicator on the right of the screen. So be aware of this. So when we view images on different planes, it therefore produces. It's therefore important for us to understand what we're looking for on the screen. So on the far left, we have a transverse view, and you can see that the indicator of the probe points to the right. So look at the corresponding image below. So the screen marker is on the same side as the probe marker, and therefore I've indicated what is right and what is left. If you similarly look at the coronal view or the sagittal view, the indicator on the probe points towards the patient's head. And if you look at the image, the images below, the cephalad area is that portion on the screen which is right next to the screen marker. Now let's talk about acoustic impedance. Acoustic impedance is the resistance to propagation of sound through a media. So whenever ultrasound waves propagate through a media, there is resistance to the propagation of this ultrasound wave, as a result of which the wave is reflected back, or it is scattered. If it is scattered, then none of the images ever come back to the probe. When ultrasound waves come out of the machine, it passes through the air. Now, the difference in acoustic impedance between the probe material and the air is very great, as a result of which none of the ultrasound waves penetrate into the tissue. So to prevent this from happening, we apply a lot of gel. When gel is applied, it decreases the difference in acoustic impedance. Therefore, now ultrasound waves will pass from the probe straight into the tissue. Focal zone is the next important concept that we need to talk about. Now, when the ultrasound wave is generated and it comes out of the probe, it has a curved shape, as shown in the image on the right. The focal zone is the narrowest portion of the beam with the highest intensity just before the waves diverge, and it is shown by the yellow image or the yellow color on the cartoon. Now, this is the area where the resolution is the best, as well as the intensity of the contrast is and the contrast intensity is the highest. So typically, we want our objects of interest to be within this area. So here is an example of a AV fistula evaluation, and you can see here in blue is the focal zone. This focal zone can be moved up and down depending on the target of interest. Now let's move to imaging modalities. The first imaging modality that I want to talk about is the B mode or the 2D mode. The B stands for brightness. This is the default modality that the machine falls to when it is turned on. When this kind of mode is, with this kind of mode, the image that is produced is a black, white, and a gray image. And the brightness of the image depends on the amplitude of the returning waves. To get the best image or the best resolution of the image, it is important to keep the probe perpendicular to the structure of interest. This way, a lot of waves are reflected back to the probe. So here are examples of 2D image, and this brings us to the concept of echogenicity. So when the waves pass through an object, if they fail to return, it will present itself as a dark structure on the screen. So if you look to your far right, we have an anechoic image. Okay, so the image is darker compared to its surrounding image. This is because the ultrasound waves have not returned back to the probe. On the far left, you will see an image which is hyperechoic, or it is brighter than the surrounding image. And this is because all the ultrasound waves that have reached the object are reflected back to the probe. Next to hyperechoic to the hyperechoic slide is the hypoechoic slide. Here, the structure of interest is slightly darker than the surrounding structure. And next to that is the isoechoic slide, where the structure of interest has the same brightness or echogenicity as the surrounding structure. Next, we come to M mode. M mode displays the movement of a particular section of a structure along a single scan line. Basically, it helps us look and measure movement of rapidly moving structures. For example, we can look at the cardiac valves. We can look at the pleura, IVC. I use it to measure diameter of the artery in a fistula, simply because the artery will dilate with systole and it will narrow down with diastole. So here is an example of M mode. So what you see here is where my cursor is the liver, and below that is the IVC. The number 1 indicates to the plane at which the M mode is being used to visualize the liver and the IVC. Below that is the graphical representation of movement. So where the number 3 points to 2 particular areas, this area right here where my cursor is the IVC. And what you're seeing is the IVC is showing narrowing of diameter and enlargement of diameter with respiration. And the measurements of these corresponding areas are shown on the far left of your screen. So the minimum diameter is 1 and the maximum diameter is 2. Next, we come to color Doppler. So whenever whenever an ultrasound beam is emitted towards a moving target, the reflected waves that come back change in frequency. This change in frequency is called as the Doppler shift, and the machine is able to recognize this and give it a color. So when the target is moving towards the probe, there is a positive Doppler shift, and the machine gives it a red color. On the other hand, if the target is moving away from the ultrasound probe, it generates a negative Doppler shift, and the machine gives it a blue color. So the mnemonic is BART, blue away from the probe, red towards the probe. So color Doppler gives us an idea of the direction of flow of blood. But besides that, it can also give us a rough idea of the velocity. So there are different hues of red and blue, and based on this, we can tell the severity, or we can talk about the magnitude of the velocity. The important use of color Doppler is to differentiate a vascular and a non-vascular structure. So if you have two anechoic structures, you're not sure if these are vascular, you turn on the color Doppler portion of the machine, and if it generates a color, then that particular structure is a vascular structure. As opposed to the B mode, it is important not to keep the probe perpendicular to the structure of interest, because at this angle, the Doppler shift is minimal. So here is an example of the aorta. So here we have the ultrasound machine looking at the aorta, and you can see on the far left of your screen, the color Doppler is red. In the middle, it is black, and on the far right, it is blue. The reason it is this way is because as blood is flowing to the air through the aorta towards the probe, it generates a red image. As the flow from the aorta is away from the probe, it generates a blue image, and it is black in the center because it's directly perpendicular to the probe, and it doesn't generate a Doppler shift. So the net result is, when you look at this image, it tells you that the flow is from left to right. Next, we come to spectral Doppler. Spectral Doppler gives us a graphic representation of velocities over time. It not only tells us the direction of flow, but it gives us the absolute value of these velocities. Okay, this is the one that is used by many of us to assess the volume of flow through a fistula. So this is what it looks like. On the top, you will get a Doppler image, and at the bottom is a waveform image of the velocities. So on the far left of the screen, where my cursor is, you will see the color scale. Anything above the white line tells us the flow is towards the probe. In addition to this, you will see various hues of red and yellow. So this tells us about the velocities. So as you can come back to the color Doppler in the middle of the screen, where the purple arrow is, you can see that there are some yellowish areas surrounded by red areas. The areas that are yellow, when you look back at the screen, at the color scale to the left, it tells you the velocities are higher. If you look below, you will see where the yellow arrow is the baseline. So flow towards the probe results in a graph that is above the baseline, If the flow is away from the probe, then this waveform will be below the baseline. Uh, the area that is circled in black is the area that is being interrogated. So here you have a gate, and what it's telling us is that the machine is interrogating the velocities only in the area between the gate. Coming to the angle of inclination, this is one of the most important things that we need to know when we evaluate flow, because if our angle of inclination is incorrect, then the flows that we record through a fistula will be poor. So the angle of inclination is the angle between the transducer and the vessel being studied. Ideally, it should be less than 60. So if you look at the image below, the red line tells you the direction of the ultrasound waves. The horizontal white line is the Doppler cursor, angle cursor. So this is the one that can be adjusted. Ideally, you want this in the middle of the vessel such that it makes an angle of 60 degrees with the red line. So if you look at the diagram on the right, if you look at this at the relationship between incidence angle and blood flow, below look at the screen where it at the diagram which has the solid black circles. So at an angle of 60 degrees, we get a flow of 500. As the angle of inclination increases, look at the blood flow. So that means the blood flow has increased from 500 almost to 600 or 650. So this is telling us that as the angle increases, the amount of error in the blood flow that we get is large. On the other hand, if the angle is less than 50, then the amount of error that we get is much smaller, and this therefore is clinically acceptable. Lastly, we come to artifacts. Artifacts are false aspects of an image that appear on the screen, but they don't really exist. One of the good things about artifacts is they tend to minimize or disappear when they are viewed in a different angle. Artifacts help us with the diagnosis in certain cases. Uh, Here are a few examples of artifacts. So the first one is reverberation artifacts, which presents itself as evenly spaced lines beyond a reflector. This is classically seen in the lung as A lines. Now the mirroring, next one is the mirroring artifact. Here, content in front of a strong reflector appears to be behind it as well. So this is typically seen when you were to look at when you have an image of the lower part of the lung, the diaphragm, as well as the liver. And so a part of the liver may appear above the diaphragm as well. Acoustic shadowing is a dark area beyond a reflecting surface. So this is classically seen when we see stones. Posterior acoustic enhancement. Here, there's an area of hyperechogenicity beyond a low attenuating fluid-filled structures. For example, a fully filled bladder. So it has the rays pass to it, and it goes to the far end of the bladder. That area appears hyperechoic. And so with that, I come to the end of my presentation. I'd be happy to take any questions. Thank you.